The military health system is the backbone of health readiness for the Department of Defense. This global healthcare organization is responsible for both maintaining and providing a medically ready force that's prepared to respond to a full spectrum of military operations. Thanks for watching this special broadcast, New Insights to Military Health Readiness Through Resilience, presented by Booz Allen Hamilton. I'm your host, Francis Rose. In a moment, we'll explore a new perspective on modern military medical care with three experts from Booz Allen. But first, let's set the stage. Here's a video breakdown courtesy of the Military Health System and the Defense Health Agency.
On the battlefield, every second counts.
Need more people for Lindenberg!
Here is where the military health system comes together to make the difference between life and death. This is where military medicine begins. In a single decade from some of the most austere places on Earth, we have built a lifeline that stretches thousands of miles. A lifeline that moves ill and injured service members from the point of injury to combat hospitals en route back home to the United States.
Blood pressure is 91/55.
Every step of the way, we deliver critical care. This remarkable health system of Army, Navy, and Air Force medical personnel cares for soldiers, sailors, airmen, Marines, Coast Guardsmen, and all who come in harm's way.
What we're doing today is digital subtraction angiography to evaluate the blood supply.
It's joint, it's integrated, it's impressive, and produced the highest survival rates in the history of warfare. But this is just one part of the military health system. The military health system is also a health delivery system. 57 hospitals, over 400 clinics around the globe. More than 9 million Americans who are military members, their families, and retirees count on us, and we deliver. Each year, over 50,000 babies, over 50 million prescriptions filled, rehabilitation, recovery.
That force will be vital to success or failure in future contingencies. For new insights to military health readiness through resilience, I'm joined by three experts at Booz Allen Hamilton: Scott Barr, Senior Vice President and Lead for Military Health; Paul Hutter, Executive Advisor for Military Health; and Dr. George Waitman, retired Army Major General and Senior Advisor to Booz Allen. Gentlemen, thanks for joining me today. Paul, I'll start with you. What is the mission of the military health system? A broad overview.
So, Francis, I'd like to refer to the video that we've just seen. And in that video were portrayed three pillars of care in the military health system. So the first pillar of care is the direct care system. That's that system of military treatment facilities, the 57 hospitals, the 400 lesser facilities around the world. They're populated by military providers in the main, and their focus is on treating service members and their family members. The second pillar is the private care system, or the purchase care system, which is also called TRICARE. This is a backstop, if you will, for the direct care system, and it is global. It is worldwide, where we have networks of private sector providers who can backstop the direct care system. The third pillar is deployment health, where we saw in the video the providers in a combat situation, but they could just as easily be in a humanitarian and civic assistance kind of mission, or reacting to a disaster in Haiti or Indonesia or wherever it might be. So with that backdrop, we then move on and talk about the mission. So the mission evolves from that, and it's very simple: to take care of the 9 million beneficiaries wherever they are in the world, but also, and as importantly, to make sure that the soldiers who go to war are medically prepared to do so, that their teeth are fixed, that they have the vaccinations, and that they are prepared to go to war. On the other side of that, you've got to make sure that the providers who are providing the care in those deployed environments are ready to go as well, that they're trained and ready to go. So the military health system has a moniker that they use that is easy to remember and I think defines the mission, which is make sure that you have a medically ready force and a ready medical force.
George, how does that differ from the private sector healthcare system, either holistically or individual components?
Yeah, that's a great question, Francis. And really the two big things I think that separate the military healthcare system are, number one, it's expeditionary. As Paul talked about, it has to be prepared on short or no notice to go almost anywhere in the world and support any number of operations. It can be combat operations, but it could be humanitarian. It could be tsunami relief, tornadoes, hurricanes, earthquakes, you name it. So it has to be prepared to go and to treat from the point of injury all the way back. It also has to be prepared to work with the host nation, because in many cases, the host nation infrastructure for medical care goes away. So you have to be able to build that. The second big difference, I think, is autonomy, in that the military healthcare system is pretty much all-encompassing and has a lot of capabilities internal to itself. And, you know, we've seen about the medical care per se, but there's also the evacuation, both locally and strategically. But there's also rehabilitation after we get our service members back to the United States. But on a bigger point, they also have a huge education and training mission as well. Very few people know it, but the military has the largest school of allied health sciences in the entire United States. They also have significant research and development capability. Another little known factoid is, at one point, the military had been involved in over half of the pediatric immunizations that were developed. But in addition to that, there's public health, there's epidemiology, and there's medical logistics. So a little bit different than your average civilian healthcare system.
And for instance, if I could just pile on, I think there's a number of analogous systems out there that we could point to. If you think about DLA, Defense Logistics Agency, or even Defense Information Systems Agency, DISA, or Special Operations Command, it's really anywhere we have a Title X responsibility executed in a joint context or environment. And so from the perspective of the military health system, DHA truly is a combat support agency, and so it's going to share a lot of those joint characteristics.
George, are there Army, Navy, and Air Force medical commands, or do they all work together now? There's been a kind of a transition over the last several years in a joint way, from what I understand.
Yeah, there sure is. Each of the medical services, Army, Navy, Air Force, has their own medical services, per se. And each are commanded by a 3-star flag officer or Surgeon General. In the Army and Navy, that Surgeon General is in charge of their medical services within their service. The Air Force is a little bit different, and wherever their medical treatment facility is, that falls underneath the local Air Force wing commander. But regardless of which service you're talking about, ultimately, all 3 of those medical services report to the chiefs of staff for those services.
So structurally, each force, Paul, has a Surgeon General.
Correct.
What's the structure there? The Surgeon General also reports to the chief, and what's that interaction with DHA like?
So the interaction with DHA is evolving. Let's put it that way. The DHA was stood up in October of 13, became fully operational in October of 15, and its responsibility is to take from the services functions that each of the 3 services used to do on their own. So it's a ticklish coordination effort in order to make that work, just as it was for the Defense Logistics Agency when it was stood up, and the Defense Information Services Agency, as Scott mentioned earlier. So and complicating this a little bit, Francis, is the recently passed National Defense Authorization Act provides even more responsibility for the Defense Health Agency. So the bottom line is that it is evolving, but here's the takeaway. The takeaway is that the Defense Health Agency is supporting those Surgeons General and their downstream operations, and the Surgeons General are the beneficiaries of that support.
So it's a cooperative effort rather than a chain of command type structure.
It absolutely is.
George, Paul used a term earlier that I thought was really instructive, and that was a medically ready force. Yeah. Define that term for me and what that means to the end user, the man or woman in uniform.
Yeah, it's a great bumper sticker, isn't it? And I think the Department of Defense realizes it catches, and it really drives home the point that they have the responsibility to make sure all those service members are ready to go, that they are healthy, they've had their immunizations, they have prophylaxis against infectious diseases or chemical or biological agents that they may meet on the battlefield, and that they know that they can go to war knowing that their family members are being taken care of back at home station. Contrast that to a ready medical force, whereas I think Paul touched on it, we make sure that we have the right providers with the right skill sets to do trauma care or humanitarian relief or whatever, and that they are prepared with their knowledge of infectious disease or tropical medicine or chemical biologic agents or whatever, to make sure that that ready force, that those service members can handle and maintain top efficiency wherever they may go and whatever they're asked to do.
I want to touch on one more thing, George. What role do medical treatment facilities play here, and how does that role change when they are actually deployed?
Yeah, the medical treatment facility, you know, when there isn't a deployment going on, function pretty much like a hospital or a clinic for outpatient and inpatient care. However, during a deployment, they serve as a resource for providers, and when I say providers, that's a broad term, meaning medics, doctors, technicians, et cetera, but they serve as a resource for the deploying medical units. And what a lot of people don't realize is the deploying medical units don't have organic providers. They rely on these MTFs to provide them during deployments. So that changes the role a little bit of the medical treatment facility. As those providers go out the door, they still have to arrange for care of the service members and the families that didn't deploy. And so to do that, they organize, they may expand hours, they may eliminate some services, they'll arrange for services to be available in the civilian community. And they can also contract significantly for those services. Now, when the deploying service members come back, if they're sick, ill, or injured, they've got to be prepared to take care of those conditions as well. They can arrange for follow-on care, civilian community, with the Veterans Administration, or even if it's determined that they have to be medically separated from the service, they'll go help the service member through those administrative procedures to make that happen as well.
Gentlemen, we'll continue the conversation in a moment. Now that we've hit the fundamentals, let's start thinking differently about the Military Health System Network. Be right back with part 2 of New Insights to Military Health Readiness Through Resilience, presented by Booz Allen Hamilton.
Maintaining medical readiness for the nation's fighting force aligns with the military's top readiness priority. For a large, complex network like the medical treatment facility enterprise, the most effective way to assure readiness is to manage risk and build resilience. To learn more, download Booz Allen Hamilton's Military Health Readiness through Reliability and Resilience Thought Piece at fedinsider.com/Booz Allen Hamilton.
Medical treatment facilities represent a critical element of the military health capability, but they're generally seen as standalone platforms that operate independently and in relative anonymity. But that changes when it's time to deploy. Here again, 3 experts from Booz Allen Hamilton. George, there are more than 50 hospitals and 360 clinics in the MTF system. You are finding that thinking differently about that structure means establishing a network of capabilities. What does that concept mean?
It's great to think of each MTF as representing part of a capability, either within that service or across all of the MHSs. And each of the services is pretty good at vertically integrating their MTFs and their all of their facilities together. However, that does not comprise the whole network. If we think of mutually supporting and horizontally integrating these MTFs, not only within the services, within each individual service, but within all 3 services, then that has to increase the strength of the whole network as far as its readiness and its resiliency is concerned.
Can I just pile on there? When you think about a system from a network perspective, you actually take advantage of 2 things. One is network characteristics, and the other is the network effect. And by network characteristics, I mean, am I effective, which is, do I have the capability? Efficient, it's a measure of my ability to execute. And robustness, that's my ability to respond, think of capacity. When you take those network characteristics, and again, apply them from the lens of a network, managing it as a network, the network effect kicks in, which is to say that when one node of that network goes down, you're able to leverage the capacity across the network to maintain that consistent level of output, or in the context of the military health system, that consistent level of readiness.
Paul, is this happening already? Are there places where people are doing this now?
It is, Francis, and it is in the sense that at the Defense Health Agency, we now have 10 shared services that are extend from a hub at the Defense Health Agency in Falls Church, Virginia, out to the military treatment facilities or medical treatment facilities across the globe. The second is an example is TRICARE, is that system I talked to you about with the private sector care. It's all over the world, and so it is there to backstop the direct care system when there isn't a facility in the local area, or if the direct care system doesn't have a particular specialist that's necessary, a neurologist, for example, then the private sector care system can pick up the slack. The third area is in a regional sense. So the military health system has established enhanced multi-service markets in geographic areas around the United States where there are 2 or more services represented with facilities. And in those markets, there is a director who is responsible for integrating and using the constellation of services that are available throughout each of the services' medical facilities to enhance the care and make sure that we're providing the beneficiaries the optimum care at the optimum time.
Scott, each service has special capabilities, things that it needs to do that the other services don't need to do. There's a possibility, I imagine there's a school of thought, that if we go to complete jointness and there's just the Defense Health Agency, that some of that might be lost. Is that something we should worry about?
Francis, I think that's a fair question. Here's what I would offer is, it's about leveraging the synergies across the services, but preserving and pulling through those capabilities that are unique to each service. In fact, it was an intent of Goldwater Nichols to preserve Title X in the execution of a joint environment. And so there are commonalities, though, right? If you think about population health, preventative medicine, vaccine development, right? The DHA stood up shared services to get at a lot of these things. But there's also a number of service-specific capabilities. For the Air Force, think of strategic medical air evacuation out of theater. Or for the Navy, undersea medicine, hospital ships are a great example, or expeditionary. And for the Army, it could be point of injury care on the battlefield. I guess my point is, thinking about this from a joint perspective does not mean we have to sacrifice service identity.
Okay, so that's the structure challenge then, Paul, is you've got DHA, that's not going anywhere anytime soon, and I think Scott makes a great case for the individual services maintaining capabilities the other services may or may not need at any given time. So how do we put all of this together? How do we make DHA fit into this structure?
So the DHA is a facilitator and is a service provider at the same time. So if you think of that hub and spoke concept that I spoke of before, the Defense Health Agency is the hub, and out from that go the spokes to the supported facilities across the globe. So that's one way it does it. The other way is has to make sure that TRICARE works. It's got to make sure that that network of providers, is there to provide the services that are required and pay for. And third, it's got to make sure the resources are available to those enhanced multi-service markets so that they can ensure the readiness of the providers who are in that network of hospitals on a regional basis.
Okay, yeah,
can I just add maybe an analogy? If you think about a power utility, right, they've got a huge, vast geographic footprint of dozens or hundreds of individual, I'll call it generators to be simplistic. And each one of those generators is managed locally. However, centrally, the mission of that power utility is to balance demand across that entire network. And that's analogous to thinking about the DHA's relationship to each one of these MTFs. It's about balancing that demand and capacity across the network.
Why is the way that blueprint is being built out important to execute now?
Well, simply because our medical system has to follow the way our war fighters fight. They fight together. We've got to provide medical services together. Examples of this include where in the video you saw an Army physician standing next to an Air Force nurse and a Navy technician, and they were working in the same operating room. So that's an example of working together. Another example that you again saw in the the video was the military transportation system of patients. So the Army is responsible for taking that patient from the point of injury on the battlefield back to the first-tier medical facility. Then the Air Force takes over and takes that patient to the higher echelons of care, whether that be in the theater or in Germany or in the continental United States. The point is that we have to work together seamlessly in order to make sure that we take care of the beneficiaries wherever they are.
George, we have about a minute left, and I want to take this and look at it the opposite direction. How does what we've talked about structurally wind up resulting in better care for the man or woman in uniform that's receiving that care?
I think to sum it up, Francis, we could say that we can get the right resources where it needs to be, regardless of uniform. And it's agnostic. We don't care across the MHS about how that care, we just want to make sure it's provided where it's needed, when it's needed, with the right skill set. And so once you do that and you keep the welfare of the service member in mind, it kind of takes the emotion out of the whole control issue about who owns what.
Gentlemen, there's more to cover. We will take a break, though. Now that you're thinking differently about the Military Health System Network, let's get to what matters: improved readiness through resilience. Thanks for watching this special program presented by Booz Allen Hamilton. We'll be right back.
For more than 100 years, business, government, and military leaders have turned to Booz Allen Hamilton to solve their most complex problems. Discover Booz Allen's advanced technical solutions for achieving mission success in consulting, analytics, digital solutions, engineering, and cyber. To learn more, visit boozallen.com. Medical treatment facilities are the medical centers, hospitals, and clinics that are the foundation of modern military medical care. To become a healthcare, high-reliability organization, the DoD has embraced 3 domains of change: leadership commitment, culture of safety, and continuous process improvement. Learn how MTFs can achieve HRO objectives. Download Booz Allen Hamilton's Military Health, Measuring Your HRO Vital Signs at fedinsider.com/Booz Allen Hamilton.
Readiness is usually seen through the lens of risk management. That looks at the ability of an organization to accomplish its mission. Resilience, though, looks at consequences. It's a key distinction with dramatic implications for the military health system. I'm joined once again by 3 experts from Booz Allen Hamilton: Scott Barr, Senior Vice President, Lead for Military Health; Paul Hutter, Executive Advisor for Military Health; and Dr. George Waitman, retired Army Major General and Senior Advisor to Booz Allen. George, how is the readiness of an MTF measured today?
Francis, probably not well. They're very good at looking at the individual MTF and deciding how it performs its mission. But what they haven't been able to grapple with is that MTF is only a node in the whole capability of, say, a service line, say surgery, whatever. To use Scott's previous example of the power grid, they're pretty good at looking at how the solar panels are working on any given day, or a wind turbine, or that given hydroelectric dam, but they're not really good at measuring the whole grid's effectiveness and efficiency from day to day.
What do we see in readiness right now? We hear about readiness all the time. The service chiefs testify in readiness over and over and over again. How is that related to risk management, though, and how do you measure that? How do you gauge that relationship so that you know where you stand?
Yeah, in an ideal world, there's unlimited resources. So no matter what challenge comes up, you have the resources to throw at, and you can continue your day job, if you will, or day-to-day mission. However, we know that it's not an ideal world. It's a world of changing missions. It's a world of constrained resources. And so you're basically managing shortages. And whenever you're managing shortages, you're doing risk management. And you're trying to mitigate and do the best job for the most people as you can. So that's what's absolutely key when we're thinking about this, is how am I going to manage these shortages so that, do I have to extend the hours of the emergency room? Am I going to have to extend the hours of a clinic? Am I going to have to decrease or increase the number of patients a nurse on the ward has to supervise, et cetera, et cetera? So all of those examples kind of give you examples of things that affect patient safety, patient access, and quality of care. So in that respect, managing shortages relates to quality of care.
Paul, I want to talk about resilience and how it affects this dynamic that George has just discussed. But give me a definition of resilience in the context of a healthcare operation.
So resilience might be defined as the ability of an individual or an organization to react positively to changed circumstances. Changed circumstances in the context of our discussion today might be a change in a military mission. Consider the change in mission from pursuing Saddam Hussein and his regular forces to pursuing insurgents in Iraq. Or it might be a change in the length of time that the mission goes on. How many of us in 2001 would have believed that as we went into Afghanistan, we would still have 8,500 troops there in 2017? Or it could be a change in the modicum of resources we have available. Just consider the impact of sequestration on the Department of Defense. And lastly, in this context, we might consider a changed patient base, where we start in a conflict situation dealing with traumatic injuries, but through the introduction of biochem or Ebola or Zika or some other kind of battlefield disease, that changes the nature of the care necessary and the nature of the providers who are necessary.
Can I just add one line around the tide of resilience and readiness? Resilience is really a measure of the robustness that you need in a network for it to operate successfully. It kicks in that network effect that we talked about earlier.
So take Scott's definition and what you just described and apply it to that dynamic that George discussed a moment ago then.
So I think what you need to think about is that resilience is more than just mental toughness or a positive attitude. It is the ability to innovate. It is the mental ability to innovate and to ensure that you are making the most out of what you have, as opposed to focusing on what you don't have. To use Scott's example that he previously used, to adjust those nodes so that we are providing the care at the right place at the right time without losing any capacity across the system.
All right, Scott, a new publication that you have out about this topic, you point out in it, for large complex networks to assure readiness, they need to manage risk and build resilience. What are some examples that you could show? Yeah,
so first let me just offer a viewpoint. I think managing risk, that's a responsibility that everyone in the military health system shares. So I wanted to sort of put that out there. But a few examples. Think about a sort of personal financial scenario. If you have an accountant balances the books. They manage the risk. But your financial planner, on the other hand, they manage a portfolio of assets. And there's the challenge that if one portion of your portfolio, if one of your assets takes a hit, their challenge is to make sure they can adjust your positions to continue to meet your long-term financial goals. So in that scenario, an accountant manages risk, a financial planner builds resilience. I'll go back to that illustration around the power utility. Again, the power utility is decentralized. There's nodes all over the country. However, and by the way, those nodes are secured and managed locally. But the management of the output, the management of the demand and capacity that flows through that network, that's centrally managed by that power utility. And so if we step back and take this to what's this mean for the military health system and the DHA, you know, an example would be the DHA ought to be able to answer the question, I know where my anesthesiologists are, and I can get them from point A to point B. Mm-hmm.
So you have a structure in this paper about where the military health agency should be. Yeah. What do we see about what they've got now? As we talked about in our previous conversation, they've got a blueprint, they're building it. Yeah. How far along are we?
Well, I think we're sort of evolving. But I do think there is a set of steps that you could take to get there. And I would start with, you know, the first thing is to set a risk agenda. And that's going to look at the most strategic risks facing the military health system today. And then you develop an architecture view or a network-based view that looks at not just the entire military health system, but each node as an element within that system. And then within that context, you've got to have total asset visibility to both senior leaders and medical planners. And you also have to be able to identify where those shortfalls are. And that's where you get the thinking of around the as-is to the to-be on how to fill those gaps. Mm-hmm. So I think the final piece I would add is, you know, what do? You test, war game, challenge, test. Get people comfortable with this model.
George, Paul, Scott, thank you very much for the conversation. And thank you for watching this special broadcast, New Insights to Military Health Readiness Through Resilience. For more information on this critically important topic, go to fedinsider.com/Booz Allen Hamilton. With Scott Barr, Paul Hutter, and Dr. George Waitman, I'm Francis Rose.